Laboratory Medicine and Neurology at Rhode Island Hospital and the Warren Alpert Medical School of Brown University. Dr. Donahue earned his MD degree from Tufts University School of Medicine in Boston, Massachusetts, where he also completed a residency in neurology, followed by a fellowship in neuropathology at RIH Brown. After spending 4 years working at the New Jersey Neuroscience Institute in Edison, New Jersey, he joined the faculty back at IRH, where he is now director of the Neuropathology Fellowship Program. In addition, he serves as co-director of the Brain Sciences course for first-year students at Alpert Medical School and director of the Neuropathology elective for third and fourth-year students. Dr. Donahue loves teaching and has received numerous teaching awards and accolades from Alpert Medical School. He has co-authored over 50 peer-reviewed publications and performed forensic neuropathology consultations for multiple medical examiner offices and jurisdictions. I will now turn it over to Dr. Donahue.
Let me, thank you, Angelica. Let me do my screen share thing. Here we go. Hopefully everyone can see. Let me put this into presentation mode. Okay. Here are the objectives. Okay. Good day, everyone.
Are you sure you're sharing your screen?
Am I not sharing the screen?
I'm not sure. I don't see it.
Let me try this again. It looks like I'm, oh, I forgot to press share. There we go. Can you see now?
Yes.
All right, great. Let me minimize that. Well, thank you, Angelica, and good day. And it's an honor and a privilege to get to speak to you today. Let me put this into presentation mode. And here we go. All right, so when I went to choose a topic for these teaching rounds, I settled on this for 2 reasons. First is that this is a very important topic that has yet to be covered in the teaching round series. As you can see from this neuropathology board exam blueprint, there are 27 questions on the. I found this on the web. There are 27 questions on the Neuropath boards that deal with this topic. And that's almost 10% of the exam, and that's not nothing. And the second reason is that this topic of general neuroanatomy and staining basically amounts to an introduction to neuropathology. And I've given many introductions to neuropathology over the years to residents in pathology, neurology, neurosurgery, psychiatry, and postdoc fellows in neuropsychology, as well as the all of the neuroanatomy and neuropathology introductory lectures that I give to first-year medical students. But never before have I ever given an introduction to neuropathology type of lecture to neuropathologists. So I'm really going to have to up my game. And I was thinking, what on earth could I possibly talk about in an introduction to neuropathology type of lecture that the average neuropathologist might not be as familiar with? And I hit upon 3 topics. So first, I'm going to open with the staining. And I'm going to talk about neuropathology specific histochemical stains. So I'm not going to talk about stains like trichrome or Congo red that are used throughout general pathology, but just stains that neuropathologists would order. And I'm not going to show a single immunohistochemistry photograph throughout this lecture. Some of these stains are still used routinely, whereas others have been relegated to the history books for one reason or another, and so they will not have instant name recognition. Secondly, I'm going to talk about gross neuroanatomy. But rather than saying something like, there's the caudate, or the putamen, the globus pallidus, the thalamus, the amygdala, the hippocampus, structures that all of us can identify with our eyes closed, I'm going to do it from the perspective of vascular territories, some of which may not be as intuitive. And then I'm going to go over selected neuroanatomic structures with interesting etymologies and tidbits that some may be less familiar with, and then conclude with a virtual slide. So now we're going to talk about the stains. So histochemical staining in general revolves around reagents differentiating solutions, and recipes. And I'm not going to be talking about how to perform these stains. That would be a lecture in histotechnology. That's beyond my area of expertise. I will mention a few of the reagents and differentiating solutions as necessary to make the points that I want to make, but this is not going to be a lecture on how to perform these stains. And some stains do require special preparation and/or fixation. All right, so let's start with the stains that are specific to central myelin. Now, any stain for central myelin can theoretically be performed on peripheral myelin or vice versa, but these are the stains that are traditionally listed as central myelin stains. The ones that I'm going to show photographs of are the Luxol Fast Blue and the Weil stain. As you can see, osmium tetroxide is included in some of these stains, and that's one of the major peripheral myelin stains. The alpha naphthylamine is carcinogenic, so that's been withdrawn. As you can see, a couple of stains require colloidin embedding. Colloidin is nitrocellulose, and that happens to be a propellant in firearms and highly flammable. And at the time that colloidin embedding was routine, that was a time when doctors and technicians routinely smoked cigarettes in the lab. And so you have to make a wrong move with a cigarette around colloidin and your lab go boom. But one of the main benefits of colloidin is you get these beautiful museum piece specimens where you get whole slides put onto a single pane of glass, and they look absolutely incredible. All right, Luxol Fast Blue is the best stain currently for assessing myelin and formalin-fixed paraffin-embedded FFPE tissue. And of all of the histochemical stains, this is probably the one that I use the most often. Central myelin is blue to dark green. Peripheral myelin is sort of light green to greenish purple. And it's very easy to see the difference in color at the Obersteiner-Redlich zone. And if you're wondering what that is, I will tell you later on. I will often combine this with H&E for routine assessment of the brain and spinal cord autopsy sessions, though it may take an extra day or two to process them. I know some neuropathologists don't like combining H&E with LFB, but I absolutely love it. The immunohistochemical equivalent would be myelin basic protein or myelin associated glycoprotein. And here are a couple of photographs. On the left is a pure Luxol Fast Blue stain of the white matter, nice deep blue. You can see the myelinated axons. There are no foci of demyelination. This is what a normal LFB stain should look like. And on the right is an H&E LFB stain showing the caudate putamen and the internal capsule, with the internal capsule staining blue because it is myelinated tissue. Now, the Weil stain is similar to the Loyez stain, but it requires thicker sections. It also uses Loyez hematoxylin, which contains lithium carbonate. Now, this stain has been around since the 1920s. It's great for colloidin embedded tissue, and that's what this stain is, a Weil stain, where the myelin is dark brown to black, and the gray matter is light beige, with the background being a very pale yellow. And this is a photograph of a whole mount colloidin embedded section. I apologize in advance. When you take a digital photograph of a pane of glass, it's hard to avoid reflections and shadows. I try to avoid them as best I can, but I'm not always successful, but hopefully these pictures will translate well. This is a photograph of one of these panes of glass with a whole brain slice on it. And then you put this pane of glass under the microscope, and you can see the various structures. Here's the gray matter. Here's the hippocampus here. You can see the alveus of the hippocampus staining black. And then here's the subependymal white matter. You can see it's staining black with the stain. Now, here are stains that are traditionally listed as peripheral myelin stains. You can see toluidine blue and osmium tetroxide are the ones that I use routinely here and have pictures of. I've never used the modified Kulczycki hematoxylin, and that requires special Fleming's fixation, not formalin, with those ingredients. I just read a review article where solachrome cyanin was actually used to stain central white matter. So just like central stains can be used in peripheral myelin stains can be used in central. And so so while solachrome cyanin can be used in central, it is traditionally listed as a peripheral myelin stain. Toluidine blue is one of the best stains for highlighting peripheral myelin in a semi-thin resin section, and I consider this mandatory to assess the state of axons and determine whether the biopsy is an axonal versus demyelinating neuropathy. I always want to look at a toluidine blue semi-thin section before signing out a nerve biopsy. Others use toluidine blue in aqueous form for rapid smears at the time of frozen section, and it can also be used to stain the storage product brown in cases of metachromatic leukodystrophy. And here is a semi-thin section with toluidine blue showing how the myelin is staining darkly around the axon. You can see some thinly myelinated axons here. This is probably represented a mild axonal neuropathy, best seen on this semi-thin section. Now, osmium tetroxide on a teased nerve fiber preparation is good for the assessment of internodal distances, the visualization of myelin ovoids in acute axonal neuropathy, and provides an optimal view of segmental demyelination, which combined with onion bulbing on the toluidine blue stained resin section can provide a convincing case of demyelinating disease. This was a case of critical illness neuropathy that I had. It was an acute disease, and you can see the fragmentation of the myelin into ovoids, as this is a severe acute axonal neuropathy. Now let's move on to the neuronal stains. The only one that I have pictures of is the crescel violet, or so-called Nissl stain. Regarding the others, the Cajal stains use pyridine, which causes sterility, and the others are not really used much anymore. The crescel violet stain is supposed to highlight the Nissl substance, which is rough endoplasmic reticulum. It's good for FFPE or pseloidin embedded tissue, and it's great for highlighting neurons without much background, which is useful for morphometric analysis. It's supposed to turn the Nissl substance and the nuclei dark purple to blue. The immunohistochemical equivalent today would probably be a NuN. And just like toluidine blue, crescel violet can be used to stain the storage product brown in metachromatic leukodystrophy. Here is basically a digital photo of the whole mount pseloidin embedded section stained with crescel violet. Put that under the microscope, and you can see the gray matter. You can see all of the neuronal nuclei at low power on the left, so it'd be great for morphometric analysis. And there's a high power of a large neuron on the right that's supposed to highlight the Nissl substance. I don't know how well that translates onto the screen. For axons and neurites, Bielszowski and Bodian are the stains that I have photographs of. Of the other stains that are listed, probably the only one that's routinely used today is the Glia stain, which can highlight abnormal neurites around neurofibrillary tangles. And I believe that also stains the glial cytoplasmic inclusions of multiple system atrophy. Bielszowski is the other histochemical stain besides LFB that I use routinely. It's a very commonly used silver stain. It's great for frozen pseloidin or FFPE sections. The axons and the neurites stain black. It's a great assessment for neuritic plaques and neurofibrillary tangles. There's supposed to be a modified recipe that shows that the plaques and tangles better than the standard, but we only do the one standard Bielszowski here, and I have no problem identifying plaques and tangles in it. Now, the background can be colorless or counterstained. My background is yellowish brown, and the immunohistochemical equivalent for axons would be neurofilament. Of course, you have to get tau for tangles and amyloid for the plaques. This is a whole mount pseloidin embedded section on the left and a low power view of it on the right. You can see all of the amyloid plaques that are staining darkly with the Bielszowski stain. And these are FFPE sections from some medical examiner cases that I've looked at. The one on the left is diffuse axonal injury. You can see the nice spheroids, the axon spheroids ballooning out from the axon very nicely. And I was thinking that perhaps the one on the right was a diffuse axonal injury as well, because it was a case of trauma. However, this was only a single focus that I could find. It wasn't present diffusely, so I signed it out as a possible infarct. But again, you can see the axon then ballooning out into the spheroid. The Bielszowski stain demonstrates these very nicely. Bodian stain is also a silver stain, but apparently this brand name Protogol is allegedly difficult to obtain. We don't do it here, so I wouldn't know. It's good for all kinds of tissue. The method supposedly has variable reliability, but then again, so does Bilshowski. Even in the best of hands, the Bilshowski can be temperamental and would require repeating. Sometimes it's overcooked or undercooked. Here's a home mount colloidal embedded section of Bodian on the left, and then a low power on the right, and then a higher power of the gray and white matter. And it's a decent stain. You can see some axons in the gray matter and many more of them in the white matter. So I mean, this is a decent stain, but here we just use the Bilshowski. Among the Glia stains, I have pictures of PTAH and Holzer. I mean, basically all of these stains have pretty much been relegated to the history books. I've never used them. I've never used any of these stains. Now, some of these go back to the 19th century. Some of them are not very specific. And so we'll just move on to the PTAH and Holzer stains that I have pictures of. PTAH, phosphotungstic acid hematoxylin, is typically an astrocytic stain. It can be used with either FFPE or colloidin. It's obscured by incidental myelin staining in the white matter. It's most useful in the gray matter and in foci of demyelination and in reactive astrocytes that stain well over the background. It stains intracytoplasmic filaments like GFAP, and that is the immunohistochemical equivalent. It's also useful for demonstrating banding in muscle fibers, longitudinal sections of muscle fibers. This is a home mount section of the PTAH and a low power view. When we go to higher power, I have a hard time finding any kind of filamentous stain whatsoever. You know, maybe I can hallucinate a couple, but I don't find this to be a very good stain at all, at least in the collection that we have here. I mean, this is a stock photo of what a PTAH stain is supposed to look like, and it looks a lot prettier. I can't duplicate that here. I like the Holzer stain better. That's a good stain for demonstrating astrocytes in their processes, can be used with all kinds of tissue. There's less incidental staining with the PTA than with the PTAH. Astrocytes are more easily identified even in the white matter. However, it requires aniline oil to differentiate, and it's carcinogenic. So this whole stain has had to be withdrawn from use. And again, the immunohistochemical equivalent is GFAP. Here is the whole mount Holzer section on the left. And you can actually see some glial filaments on the right. So this does demonstrate the stain, I think, a lot better than the PTAH. And here is a stock photo just for comparison. You can see the nice glial cell processes, but we really can't use Holzer anymore because it's carcinogenic. The last category of stains I will go over are the neuroendocrine stains. I will show you a picture of a Grimelius stain, which is a silver stain, looks very similar to methenamine silver. The Cherukhian Schenk is an alternative silver stain that probably works just as well. The PAS orange G stain is of historical interest because that stain provided the basis for categorizing pituitary cells as acidophils, basophils, and chromophobes. As I said, the Grimelius stain is a nargyrophilic silver stain. It highlights neuroendocrine granules. It's useful in FFPE tissue. The neuroendocrine cells turn black with the background being pale yellow to green. Immunohistochemically, you would order a chromogranin, a synaptophysin, or an NSE. I ordered a Grimelius stain once, and that was back in 1997 in a paraganglioma, and I still have a Kodachrome of it. And so this is a suboptimal photograph that I had to take by putting the Kodachrome inside a projector and then taking a digital photograph of the screen. So you can see some dark granules here that likely represent the neuroendocrine granules of the paraganglioma. Today we would just get a chromogranin stain or synaptophysin stain and it would light up. But that was the one time that I used a Grimelius stain. Okay, so let's move on to section 2, which is the gross neuroanatomy based on vascular territories, as I demonstrate a PCA infarct there. So this picture is just to refresh your memory of the circle of Willis. It's pretty self-explanatory. I will say that there are some smaller vessels that are not depicted in this picture that I will discuss. One is the anterior choroidal artery, which branches directly off of the internal carotid artery. And then there are smaller branches off the posterior communicating artery. After the bifurcation at the top of the basilar artery, you have thalamoperforating arteries, followed by the posterior communicating artery, followed by thalamogeniculate arteries, followed by the posterior choroidal artery, then temporal and occipital branches, and then terminating in the parieto-occipital and calcarine arteries. And there are subtle variations from person to person, and so it's not a one size fits all, but when we talk about what branches off of what, we tend to go with what occurs most commonly. Okay, so these are gross autopsy photographs with my drawing the vascular territories on top of them. So the anterior cerebral artery covers the medial part of the brain, the medial part of the motor homunculus. So a clinical ACA infarct would have leg weakness more than face and arm weakness. And the middle cerebral artery is more lateral. And so weakness in the MCA territory is face and arm more than the leg. And the more posterior we get, now we can still see the anterior cerebral affecting the medial structures and the middle cerebral artery affecting the lateral structures. And then here is your anterior watershed area in between the two vascular territories that I often sample looking for ischemic changes. I include the head of the caudate nucleus inside the anterior cerebral territory. Most of the head of the caudate is supplied by the recurrent artery of Hubner, which is a branch of the ACA. The superior part of the head and the body of the caudate are typically supplied by lenticulostriate branches of the middle cerebral. And the tail of the caudate would then be in anterior choroidal artery territory. Now we start to get busy in terms of the vascular structures. This is the coronal section through the mammillary bodies. We still have anterior cerebral medially and middle cerebral laterally. You can see encompassing the lateral basal ganglia, the lenticulostriate branches. Now the posterior cerebral territory is starting to appear in the inferior temporal cortex. And now we have anterior choroidal territory appearing. Now, I've read some sources where the medial globus pallidus is actually supplied by the recurrent artery of Hubner, a branch of the ACA, and that may be true in some individuals. However, the majority claim that the medial globus pallidus is supplied by the anterior choroidal artery. And so structures like the globus pallidus, the optic tract, the amygdala, parts of the thalamus, even the lateral geniculate nucleus are supplied by the anterior choroidal. Now, I also read where the lateral geniculate, medial geniculate nuclei are supplied by the aptly named thalamogeniculate branches off the posterior cerebral artery. However, some books also claim that the lateral geniculate is anterior choroidal. So if you have an infarct that involves the globus pallidus, the lateral geniculate, and the optic tract, the posterior limb of the internal capsule, that would all be anterior choroidal territory. And when the posterior limb of the internal capsule is involved, the weakness would then be face equal to arm, equal to leg, unlike the cortical patterns of weakness that I discussed earlier. Now, far medially, we have the mammillary bodies, the hypothalamus, and most medial part of the thalamus. Some books claim that these are all supplied by deep branches of the posterior cerebral artery, which theoretically is true. The posterior communicating artery could be considered a branch of the posterior cerebral, and the anterior nucleus of the thalamus supplied by the posterior choroidal artery, which is also a deep branch of the posterior cerebral artery. But this particular atlas says that it's supplied by the posterior communicating artery, and there is a there is a polar artery that supplies part of the thalamus, as well as posteromedial central artery perforators that come off of the PCOM that supply the medial thalamus, hypothalamus, and mammillary bodies. As we now go posteriorly, Now we're at the level of the pineal gland, which is still considered posterior choroidal territory. Now the posterior thalamus would be supplied by the thalamic perforating arteries. And here we have the anterior cerebral still affecting the medial cortex, middle cerebral, lateral cortex. Now the posterior cerebral is encompassing a larger part of the inferior temporal cortex. And with the hippocampus, hippocampus is also traditionally listed under anterior choroidal artery territory. So we still have a little bit of that. And now we're getting even further posterior, and we have now just anterior, middle, and posterior cerebral artery territories, with posterior cerebral becoming the most dominant. And here in the medial parietal occipital cortex, you have a triple watershed area between the anterior, middle, and posterior cerebral arteries that you can also sample for ischemic changes. In the brainstem, on the left, we have the midbrain. The colliculi fall under superior cerebellar artery territory. Posterior choroidal artery also supplies a part of the lateral midbrain, with the medial midbrain being posterior cerebral artery perforators. This is where you would get a Weber syndrome, which is an infarct involving the ipsilateral. It's an infarct involving the oculomotor nerve and the cerebral peduncles. So you would get an ipsilateral third nerve palsy with contralateral weakness, face, arm, and leg being equal. And here over in the pons, the majority of the pons is comprised by the basilar artery, with a little bit of anterior inferior cerebellar artery far laterally. You get occlusion of the basilar artery, and you end up with locked-in syndrome, where the patients are aware, but they're quadriplegic and they can only move their eyes for communication. And then lastly, we're going to deal with the medulla and the cerebellum. Here is the medulla. You can see in the medial medullary syndrome, which is traditionally anterior spinal artery territory. And then here we get a little bit more lateral. We get into vertebral artery, and then we start to get into posterior inferior cerebellar territory far laterally. In the cerebellum, it's very intuitive. The superior cerebellum is superior cerebellar artery. The anterior inferior cerebellum is ICA, and the posterior inferior cerebellum is PICA. Now, I always tell the students every year about lateral medullary syndrome. And traditionally, they say that the books say lateral medullary syndrome is caused by a pica infarct. I disagree with that, because you can get a pica cerebellar territory infarct without getting a lateral medullary infarct. It's my belief that lateral medullary infarcts are caused by small penetrating arteries that come directly off the vertebral artery. So I would extend this vertebral artery diagram a little further out. And so, and the same could also be true for the medial medullary syndrome. I mean, it is listed as anterior spinal, but the anterior spinals are formed from branches that come off the vertebral arteries. So medial medullary could also be small penetrating vessels that come off the vertebral artery. I always tell the students, if you see pica as the choice on a multiple choice exam for a lateral medullary syndrome, then go with it. If you see vertebral as the choice, go with that. If you see both vertebral and pica as choices, that's not really a fair question. But then you should probably still go with pica, because that's probably what they're after. But like I said, I think it's small penetrating vessels directly off the vertebral artery. So that concludes section number 2. So now I'm going to move on to microscopic neuroanatomy with the etymologies and tidbits. This is basically going to be a whip around of various neuroanatomic structures. And it's going to seem like it's not very unified, because I'm going to be jumping around from topic to topic, hodgepodge style. But the unifying theme of this section is that you're sitting around a multi-headed scope with me reviewing brain slides to sign out a case. And I'm rattling off random factoids off the top of my head about what we're looking at to make the sign out more interesting and educational. And it's simply impossible to cover all of neuroanatomy and every tidbit in this limited amount of time. So if I happen to omit your particular favorite neuroanatomic structure or tidbit, then type a comment in the chat box or shoot me an email, and I'll be happy to include your tidbit the next time I sign out a case, and I'll give you credit for it. Let's start with the calcarine cortex, or the line or stria of Gennari. Calcar is the Latin word for spur, and the calcarine gyrus kind of looks like a spur that might come off the side of a boot, which could be where it got its name. But here you can see this line with the naked eye grossly, and then here it is on an H&E LFB stain under the microscope. Very easy to pick out grossly and microscopically. The line of Gennari was named after Francesco Gennari. He was an 18th century Italian physician. He originally described it when he was a medical student, but he didn't publish his findings until 1782. And the French anatomist Vic Desir, who of the tract of Vic Desir fame, the mammillothalamic tract that connects the mammillary bodies with the anterior nucleus of the thalamus, is also known as the tract of Vic Desir, as I always tell the fellows and students every year. But as it turns out, the line of Gennari was also known as the line of Vic Desir for about a century. And then Heinrich Obersteiner of Obersteiner-Redlich zone fame suggested the line of Gennari in 1888 when he reviewed the publications of Gennari and Vic Desir and realized that Gennari beat him to it by a few years. And so while Gennari was difficult, he was self-defeating, and he died a sad and bitter man, he has this posthumous claim to fame, and now everybody knows his name. The line of Gennari is actually the outer band of Bell-Arget in the primary visual cortex. Now, there are both outer and inner bands of Bell-Arget that are tangential myelinated fibers in the cerebral cortex. They run parallel to the surface. They're most prominent in the sensory cortical areas because of the high concentration of thalamocortical fibers. They are most obvious in the calcarine cortex because of the large number of visual fibers coming into synapse in the calcarine cortex. And these lines were described by the French neurologist, psychiatrist Bell-Arget, Jules Bell-Arget, in 1840. The inner band of Bell-Arget is a lot harder to see. If you strain hard, you might be able to see it in that picture that I showed you earlier. But of course, the outer band, the line of Gennari, is the most obvious. Here is a slide of, this is a gross picture of a glass slide of medial temporal cortex detailing some of these structures. You can see the hippocampus here, area CA1 is summer sector, CA4 is the hilum of the dentate gyrus, areas CA2 and CA3 are in between. Here you can see the lateral geniculate nucleus, the tail of the caudate nucleus. Here is the alveus of the hippocampus becoming the fimbria of the fornix. Here's the lateral ventricle. Here's the dentate gyrus. Here is the subiculum with the clouds of Arnold, which I'll tell you about those in a bit. And then the entorhinal cortex. And then here we have the parahippocampal gyrus, the collateral sulcus, and the fusiform gyrus. And here are some etymologies of some of these structures. I like these etymologies. I took 4 years of Latin in high school. And so it's interesting to hear what the ancients thought of these structures and how they named them. The limbic system is derived from limbus, which is border, because the limbic system forms a border around the brainstem. The cingulate gyrus, derived from the Latin cingulum, it's a belt that's above the corpus callosum. Hippocampus, as we know, is the Greek for seahorse. Ca is cornu ammonis, or Ammon's horn. Ammon is an Egyptian deity with the horns of a ram. And he was adopted by the Greeks as an epithet of Zeus, and later incorporated by the Romans as Jupiter. He must have been a bigwig in Egyptian mythology. But he had the horns of a ram, and so Ca is the Ammon's horn, another name for the areas of the hippocampus. Ungus is the Latin for hook. It's the anterior end of the parahippocampal gyrus. It does kind of look like a hook. The alveus of the hippocampus. Alveus is the Latin for trough or canal. That linear structure kind of looks like a canal. Fornix is the Latin word for arch. If you look at the fornix in 3 dimensions, it has the structure of an arch. The fornix begins, the alveus of the hippocampus becomes the fimbria of the fornix. That's the Latin for fringe, so it's right at the fringe of the fornix. The amygdala is a Greek word for almond. It looks like an almond. And thalamus is derived from the Greek meaning bridal couch or wedding chamber. I'm not quite sure how that fits in. The pulvinar it means pillow or cushion, so it provides a pillow for the wedding chamber. I have a hard time looking at the thalamus and thinking of wedding chamber when I see it. Here are the clouds of Arnold in the subiculum. I've seen these clouds many times, but I never actually knew that they had a name. These are clusters of neurons that appear just below the pial surface. as the temporal neocortex transitions into the subiculum, and subiculum is the Latin for support because the subiculum provides the physical support beneath the central hippocampus. It's named for the German neuroanatomist Friedrich Arnold, who described them in that publication. This is not the same Arnold of the Arnold-Chiari malformation. That was Julius Arnold. And then, of course, you have Arnold Pick, who described Pick's disease. So we have a lot of Arnolds in the history of neuroanatomy and neuropathology. Here's a photograph of a glass slide of basal ganglia. You can see the caudate putamen, the globus pallidus, the lateral and medial medullary laminae separating the parts of the globus pallidus. You have the external capsule, claustrum, extreme capsule, insular cortex, or the island of Ryle. Here you have the anterior commissure and the substantia innominata. And caudate is derived from Latin, meaning having a tail. Obviously, the caudate we know has a tail. Putamen is the Latin for shell, looks like a shell. Globus pallidus is pale sphere. It looks like a pale sphere. Striatum is derived from striatus, meaning striped, and corpus striatum, which is the caudate and putamen. Corpus is body, so corpus striatum is striped body. Lentiform nucleus is from the Latin lens or lentil, and forma or shape, so shape of a lentil. I don't eat lentil soup, so I'll have to take the ancients' word for it. Substantia nigra is obviously black substance. Insula is Latin for island, and then the insular cortex is also known as the island of Ryle, or as I like to say, because it rhymes, the Isle of Ryle, because it was first described by Johann Christian Ryle, Danish physiologist, late 18th, early 19th century. Claustrum is the Latin word for wall or barrier. And when you're looking at the basal ganglia, you got this line separating the external from the extreme capsule, so it looks like a wall or a barrier. That's easy to understand, but the claustrum itself is a poorly understood structure because of its complex shape and deep location. I always tell the students you can't test for claustral lesions based on your instruments in your black bag. It's thought to be crucial to neural homeostasis. It integrates multiple sensory inputs, thought to promote reward-related behavior. There are changes in the structure and volume of these diseases, of the claustrum in certain neurodegenerative diseases, but in general, we don't know what the claustrum does for sure. The pencil fibers of Wilson, you can see they give the corpus striatum its striped body appearance. You can see that there are these islands of white matter within the caudate and putamen. They are small white matter bundles specific for the caudate and putamen. They are also called striatopallidal fibers because they connect to the globus pallidus. They were described by Sir Samuel Alexander Kinnear Wilson, an American-born British neurologist of Wilson disease fame, using the Marchi staining method for myelin. Here we have the anterior commissure and the substantia innominata, and within that we have the nucleus basalis of Meinert, which is part of the substantia innominata, which is Latin for unnamed substance. It's below the anterior thalamus and lentiform nucleus. It is the major source of cholinergic input to the cerebral cortex. It is severely depleted in Alzheimer's disease and dementia with Lewy bodies, which provides the pharmacologic basis for using anticholinesterase inhibitors to treat palliatively Alzheimer's. Named after Theodor Meinert, who was a 19th century German-Austrian psychiatrist, neuropathologist, and anatomist. The indusium griseum is one of my favorite neuroanatomic structures for arcane trivia. Here you can see the cingulate gyrus on either side. Here's the corpus callosum. And the indusium griseum is this narrow gray matter structure that rests on the superior surface of the corpus callosum. Indusium griseum is Latin for gray underwear, and corpus callosum is Latin for tough body. So think of the indusium griseum as the fruit of the loom on the tough body that is the corpus callosum. It was first described by Lancisi of Italy in 1712, who thought that the corpus callosum was the seat of the soul, unlike the pineal gland. And he thought the medial longitudinal stria, or the nerves of Lancisi, were the pathway for consciousness. These longitudinal stria are so small that I couldn't find a good picture of them. He thought that the lateral longitudinal stria were merely folded up edges of the corpus callosum, so he only gets credit for the medial longitudinal stria. But there are medial and lateral longitudinal stria. The indusium griseum is an embryologic dorsal remnant of the hippocampal formation and fornix. So it's technically part of the limbic system. It is innervated by cholinergic, dopaminergic, noradrenergic, serotonergic, and GABAergic neurons. So maybe it has some kind of function, but its true function is unknown. And I always teach it as a vestigial remnant of the hippocampal formation. I always like seeing subthalamic nucleus on section. Looks very nice and well demarcated here. It's named after Jules Bernard Louis, who's a 19th century French neurologist. And I mention it because it's also known as the body of Louis, and that's where Louisian comes from in the condition dentato-rubro-palatal Louisian atrophy, or DERPLA. You have dentate nucleus of the cerebellum, red nucleus of the midbrain, globus pallidus externa, and the body of Louis, or subthalamic nucleus. Lesions in isolation alone can cause hemibolismus, these wild flinging movements, but it's not necessarily restricted to the subthalamic nucleus, but that's what is classically taught. The pineal gland is derived from the Latin pinea, or pine cone, because it looks like a pine cone. Descartes considered it the seat of the soul in the 17th century, but today we know it secretes melatonin. It's involved in circadian rhythms, and it's one of the circumventricular organs, or the parts of the brain that lack a blood-brain barrier. One of my favorite anatomic derivations is the habenular nuclei. It's derived from the Latin habenula, which is a diminutive form of habena, which is a small strap or rein. If the pineal gland is the seat of the soul, and it runs the brains via the reins of the habenular nuclei, as though it was sitting in a chariot. So these nuclei comprise the epithalamus along with the pineal gland. They project to the interpeduncular nucleus of the midbrain via the habenulo-interpeduncular tract, which is also known as the fasciculus retroflexus of Meinert, same Meinert as the nucleus basalis. And it's thought to modulate fear, anxiety, risk, reward, pain, sleep, reproductive, and aggressive behaviors. We finally made it to the Obersteiner-Redlich zone. This is the zone of the trigeminal nerve. Now, I've always seen the transition zone between central and peripheral myelin under the microscope, but I had no idea it was called this until Doug Anthony mentioned it. This is the root entry zone where central myelin meets peripheral myelin and oligodendrocytes meet the Schwann cells. It's a potential site of vascular compression and trigeminal neuralgia. The most common tumor in the zone is thought to be a schwannoma. However, some feel that schwannomas in this area arise lateral to the zone. And it was named after Obersteiner and Redlich, Austrian neurologists. They first described it in the spinal nerves of patients with tabes dorsalis. I always say that whenever the medial longitudinal fasciculus does this loop-de-loop in the midbrain at the level of the decussation of the superior cerebellar peduncle, the two nuclei that you see embedded in the MLF, that's the trochlear nuclei. And this loop-de-loop is the pars mediana of the MLF. And here you can see these are motor neurons because of the prominent missile substance. The trochlear nucleus is located medially in the caudal midbrain at the level of the decussation of the superior cerebellar peduncle and the MLF pars mediana. The axons form the trochlear nerve, which is responsible for depression and intorsion of the eye, and lesions cause vertical diplopia. Pons is the Latin word for bridge because the pons forms a bridge between the cortex and the cerebellum and the cortex and the spinal cord. This is a photograph of the pontine tegmentum with the mesencephalic trigeminal nucleus in the lateral wall. If you look at higher power, these neurons look like ganglion cells, like they belong in a dorsal root ganglion. And in fact, that's what they are. They are the only first order primary sensory neurons that are completely within the CNS parenchyma. It's like having a dorsal root ganglion inside the brain. They run along the lateral edge of the periaqueductal gray. They do focally extend into the superior pons. They are responsible for proprioceptive input from the face, position, vibration, 2-point discrimination, and they're also part of the jaw jerk reflex. These are the cranial nerves that are within the cavernous sinus. And this mnemonic, oh, Tomcat, was taught to me by Fred Merck, who was a PhD in anatomy at Tufts Medical School. And I never forgot this mnemonic. You have the oculomotor nerve, the trochlear nerve, the ophthalmic division of the trigeminal, the maxillary division of the trigeminal. You can see the internal carotid is most medial, and then you have the abducens just laterally to it. Recall that the mandibular division of the trigeminal nerve does not pass through the cavernous sinus. That was always a great true-false question back in the day when you could actually ask true-false questions on exams. The abducens nerve is closest to the carotid artery within the cavernous sinus. So patients with carotid cavernous fistulas often will present with a sixth nerve palsy. They are not able to abduct their eyes. The lateral rectus is paralyzed. This is the medulla. You can see part of the inferior olivary nucleus here. This is a pretty nondescript part of the medulla, but when you go to higher power, you can see this motor nucleus, the nucleus ambiguus. It's located in an ambiguous location at the level of the dorsal accessory nucleus of the inferior olivary nucleus. It supplies branchial motor fibers via the vagus, the cranial nerve 10, which is the Latin word for wandering, because the vagus nerve wanders all over the body and internal lower organs once it leaves the brain. It supplies branchial motor nerve to those muscles, palatal pharyngeal, upper esophageal, laryngeal, and the glossopharyngeal nerve to the stylopharyngeus muscle. It's one of the nuclei that are affected in the lateral medullary syndrome that I mentioned earlier. So these patients present with hoarseness and trouble swallowing, depressed gag reflex. The arcuate nucleus is located inferior to the medullary pyramids. And inferior, anterior, it's this narrow nucleus here. And just inferior to that, this picture is upside down, that's why I say inferior. You can see the anterior external arcuate fasciculus, this myelinated tract. The arcuate nucleus is on the ventral surface of the medulla overlying the pyramid, or it's inferior to the pyramid if it's oriented in the standard way. It's a precerebellar nucleus. It's proposed to play a role in regulating respiration. Some axons project to this anterior external arcuate fasciculus and then to the cerebellum via the inferior cerebellar peduncle, whereas others project to the medullary reticular formation, presumably to regulate the respiration. Here is the cerebellar cortex of a 4-month-old, where you can see the 4 distinct layers: the external granule cell layer that will involute by the age of 1, the molecular layer, the Purkinje cell layer, and the internal granule cell layer. So if you look at this at low power and you see an external granule cell layer, you know you're dealing with an infantile cerebellum. And what I always like to do with the rotators and students is fool them by going to high power on the granule cell layer and ask them what neoplasm is this, because this resembles a benign neuroendocrine tumor. You can hallucinate Homer-Wright rosettes in there. It looks kind of like, is it a neurocytoma, pineocytoma? But no, then I go to lower power. No, it's cerebellum. And then the last structure will be thoracic spinal cord. You can see the anterior and posterior horns, as well as the various columns, which are also called funiculi, which is the Latin for cord or rope. So you have the anterior, posterior, and lateral columns, or funiculi. This is at the level of the, this is the thoracic spinal cord. And you can see the intermediolateral cell column and the far lateral gray matter. These are second order neurons in the hypothalamic, in the autonomic pathway that starts in the hypothalamus, then down to the intermediolateral cell column before crossing over to the superior cervical ganglion and then ascending to the eye constrictors. You have the central canal here, and then you have Clark's nucleus. Clark's nucleus is the posterior thoracic nucleus, or Clark's column. The nucleus dorsalis of Clark is in the intermediate zone of the spinal cord. It's a major relay center for unconscious proprioception. These axons form the dorsal spinal cerebellar tract and ascend through the inferior cerebellar peduncle to the ipsilateral cerebellum. It's one of the tracts that degenerates in Friedreich's ataxia. And it's named after Jacob Lockhart Clark, the 19th century British anatomist and neurologist. So now I'm going to flip to the virtual slide. It's a 51-year-old man with a seizure disorder with sudden death. It's a medical examiner case. I have to exit the presentation because I can't get that link to work. So I will bring the slide over here. Hopefully I can maximize this. Okay. So this is not a pathology lecture, but I mean, anyone who looks at this can see right away this is severe hippocampal sclerosis. You can see how the hippocampus is just devastated with severe neuronal loss in this part of it. You can see area CA4 still relatively intact. Part of CA1 is intact. I'm just showing you this slide just to reiterate some of the anatomy of this region. Here you can see the subiculum. The clouds of Arnold are not very obvious in this particular section. You maybe see a couple of them emanating from the subiculum, and then you go into the entorhinal cortex. And then here you can see some choroid plexus. I always ask the students how much CSF does the choroid plexus produce at any one time. And I always think of it as the CS, we have 150 cc's of CSF at any one time, and it turns over 4 or 5 times a day. And so I say anything from 400 to 500 cc's of CSF are produced per day by the choroid plexus. And here you can see, here's the ependymal lining, here's the alveus of the hippocampus becoming the fimbria of the fornix. Here is the lateral geniculate nucleus, somewhat chopped off there. Here you can see the tail of the caudate with the few pencil fibers of Wilson mixed in. And then we have this gray matter structure in between the lateral geniculate and tail of the caudate, and I'm not 100% sure what this is. I tried to look it up in an atlas. The best I could find was stria terminalis, but that's a white matter structure. And so it makes me wonder if this is in fact part of the bed nucleus of the stria terminalis, which integrates limbic function and is most well developed in animals. But that's your medial temporal lobe anatomy in a case of hippocampal sclerosis. So I believe that is it. It's going to be my last slide. Here's the Q&A. So I will stop there and take any questions.
Thank you, Dr. Donahue. At this time, we'll move into Q&A. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner. Once you've asked your question, please remute to avoid background noise. Okay, we'll give people a few seconds to get their questions in there. And it looks, there's a thank you. I was going to say this is a remarkable lecture, and I think my students are going to have some more challenging questions next year in the neuro course.
Hello. Oh, sorry.
Yep.
Yes, this is Murat Kaptan, University of Arkansas. Thank you very much indeed. That was both very practical and historical as well. So it took me some years back. And, it's just this Obersteiner-Redlich zone is interesting because based on my interactions with the neurosurgery colleagues and reading some neurosurgery literature, the terms of Obersteiner-Redlich zone, transition zone, root entry zone have all been used interchangeably. And it looks like we as neuropathologists refer to the OR zone as the actual line between the central and peripheral myelin, whereas neurosurgery folks are referring to transition zone or root entry zone as the distance between Obersteiner-Redlich zone and the actual CNS parenchyma. So there is that variable few millimeter distance between the actual zone and the parenchymal surface where it is still central myelin, where you can get, central nervous system diseases in the peripheral nerve. And lastly, I don't know what your students do with all this terminology that you use and the Latin, but I came across to a lot of people, both students and even residents, who don't know that spinal cord is actually medulla spinalis. So when somebody says medulla, well, which one? Medulla oblongata or medulla spinalis? So what is medulla spinalis? So I find that always interesting, but thank you very much.
Always leave as Latin scholars.
Yeah.
Thank
Then
you.
we have a question in the chat from Dr. Deepa Rao. Given the histologic differences in myelination between the CNS and PNS, is there a difference in nerve conduction velocities too?
Well, thank you for the question. I'm not sure if we know the answer to that. I don't know if it's physiologically possible to do nerve conduction studies of central myelin. I mean, I'm certainly amenable to looking this up and seeing if that's true. I mean, it wouldn't surprise me if there might be some differences. I mean, myelin basic protein is common to both of them. There are some unique proteins that are there are antigens that are unique to central myelin, and and the antigens that are unique to peripheral myelin. That's why multiple sclerosis tends to only affect the central myelin, and Guillain-Barré syndrome tends to only affect the peripheral myelin. So there are definite antigenic differences. Whether that translates into differences in nerve conduction velocities, that I do not, I am not 100% certain of. I would have to check. I would have to do some research in order to be able to try to properly address that question.
Okay, and then I have another question from Dr. Ansaregi. Thank you for the superb presentation. One question, can you identify fastigii, globose, and emboliform nucleus from the dentate? If so, is there a special slicing angle or plane?
You know, that's an interesting question, because I often try and look for these other deep cerebellar nuclei, and other than the dentate, I have a hard time seeing them grossly. But by the way, my mnemonic for the deep cerebellar nuclei, going from lateral to medial, is don't eat greasy food. So it's dentate, emboliform, globose, and fastigial. And then going from medial to lateral, it's fat guys or fat girls eat donuts, which is fastigial, globose, emboliform, dentate. But I usually cut the cerebellum parasagittally. I think in order to attempt to find fastigial, globose, and emboliform nuclei, and by the way, the globose and emboliform together are called the interposed nuclei. I think in order to have a shot at trying to find those, you're going to have to cut the brainstem and cerebellum together transversely. And then you have the best chance of seeing these medial structures. I don't know if there is a specific slicing angle or plane in order to get them, but I would think having to cut them transversely instead of parasagittally would be a good first start. Usually I don't have to identify them from a pathologic standpoint, so I tend not to go out of my way to try and find them, but I think that's the best way to at least attempt to find them, is attempt a transverse section. So you have brainstem and cerebellum together with the fourth ventricle, and then you might be able to get a good look at the medial white matter and these medial nuclei.
Okay, and then there's a few more thank yous. And I think it's 11 o'clock. So I'm going to say thank you again. And hopefully I'll see a lot of people in Florida.
I will stop my screen share.
Yeah.
All right. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. I've also entered it into the chat box. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again, Dr. Donahue, for an excellent presentation. This concludes the session for today.
Good job, John.
Thank you.